So good afternoon, everybody. My name is Katie Gilles, and I am the Director of the Healthcare Assessment Programme and Senior Research Fellow based at the Health Services Research Unit at the University of Aberdeen. And first of all, I'd like to thank the symposium organisers for inviting me today to talk to you about making trials less leaky and to explore some of the ways that we can hopefully improve retention in clinical trials. So to give you a bit of context, as I said, I'm based in Aberdeen, and for those of you who don't know where Aberdeen is based up here in the northeast of Scotland. Our days are quickly getting shorter, winter is definitely on its way. The University of Aberdeen is an ancient university. It was established in 1495, and we have this beautiful old building down at the heart of our campus in Old Aberdeen. But like many of you, I am not on campus right now, and in fact I am sat in my spare bedroom. I do have these jeans on, but I have on a different top today, and I'm here talking to you today. So just to give you a bit of context about where I am and what I'm doing. I'd also like to start as well by setting some expectations. So I am not going to give you a magic solution that will fix all of your retention problems. So if you came here to find that out, then I'm sorry to disappoint you, but that's not what's going to happen. What I am going to do is I'm going to highlight the problem of poor retention and what that means for trials. I'm going to then give you some examples of some of the recent work we've been doing and recent work from others that really starts to drill down and give light to this area that really needs additional attention. And then I'm going to give you some potential solutions, but with some added caveats. And hopefully through this, you will stick with me throughout this talk as well and be retained at the end. So why should we care about retention? So the main issue for poor retention is that it impacts on the internal and external validity of our trials. So in other words, the accuracy of our results. And what that means is that at best, those results might be inconclusive, but at worst, they might actually be completely unusable. And all of those people who took part in your trial, all of their contributions will be wasted. The other issue that we should care about is that by not addressing the problem of poor retention has significant implications for cost. So if we think that these trials are going to take longer, clearly that is a cost, but also if we take on the consideration that the way that we mitigate for many of the problems of poor retention is by inflating sample sizes, so making an already tricky job, recruitment, even trickier, this seems slightly back to front. And if we drill down deeper, recent estimates of the cost of trial participants came in at around £8,500, okay, in the UK. If we consider that a trial that has a sample of 250 people, it uses an inflated sample size of 10%, so an extra 25 people, that will cost over £200,000 to recruit those additional people, when in actual fact, we possibly could have retained those other people at a fraction of the cost. The other issue as well for me is really thinking about the ethical implications. So if trials take longer, we're going to potentially expose additional people to unnecessary harm from having to test the intervention more times on more people. But also we're foregoing patients' effective treatments by not being able to produce our trials on time and on target. So to me, these are the three issues that we really need to consider when considering the big impact of retention. So what's the scale of the problem? So as I said, we tend to inflate our sample sizes. There's a general rule of thumb that anything less than 5% we might not need to worry about, although I'd probably argue that we should always be trying to get to zero. But anything over 20% is a real problem and completely futile for your trial. So this spot between 5 and 20 has different implications. It's still a problem, but it has different implications for your trial. So recent studies have shown that 50% of trials have lost a follow-up of over 11%, and around half of all clinical trials could have been overturned if the results of the non-retainers were in fact known. And this has been termed the fragility index. And I think it's a really nice way to think about how retention impacts on trials, making it fragile. And the title of my talk was Making Trials Less Leaky. So if we think about all those recruited participants as the water flowing into the system, the problem with retention is that it's probably not going to spring one massive leak unless your trial's been designed really badly. It's probably that there's going to be little leaks all along the way, but all of those leaks cumulatively end up in a flood, not a trickle. So we need to address each of these different small changes to have potentially big impacts. So what do we do currently? So a survey of UK CTUs done by Anna Kearney and colleagues in Liverpool a couple of years back showed that standardly 70% of CTUs surveyed were using newsletters. Hardly any evidence, in fact, less than hardly any, basically no evidence to support their use. They were also using prepaid envelopes. Again, what's the evidence? And also using electronic prompts or reminders through telephone calls or email messaging. And there is some evidence starting to generate on that, and we'll come to that later on. But often what happens with these is that these are done reactively, these strategies, rather than built in proactively. So retention is this thing that we worry about after it's happened. So we always plan for recruitment, but retention gets a bit of an afterthought. And I think that's wrong. I think we should be planning for it from the beginning. And probably one of the reasons that we think about it after the event is, unlike recruitment, or hopefully we shouldn't be doing recruitment like this, is with retention, you can consider analysis, and you can account for it in your analyses through methods such as imputation. And last year at this symposium, Erica Daly gave a really nice talk about some of the implementation issues and analysis issues around these types of approaches. So hopefully I've convinced you that retention is a problem, that there are reasons why we should care about and what's kind of happening at the moment. But it's not just me who thinks it's a problem. So a couple of years ago, a prioritization exercise amongst UK CTUs was conducted. And just to say, this piece of work is soon to be replicated involving other countries, and I know Ireland through Declan Devan will be included, as well as others. But in this existing piece of research, the top 3 priorities for research were recruitment, methods to minimize attrition, and choosing appropriate outcomes. So those 2 came in joint second position. And what's interesting is actually choosing appropriate outcomes is intrinsically linked to methods to minimize attrition. So I really think retention is starting to have its day. And just to make this point, so ORCA, for those of you who haven't come across ORCA, it's an online database of recruitment and retention research. It's run by Anna Kearney in Liverpool. I would encourage you to go and have a look. It's a fantastic resource. But what it highlighted to me when I was in preparation for this talk as well was that within ORCA, there are nearly 4,000 articles to do with recruitment on research, and just over 1,000 on retention. So again, there's this constant focus on recruitment, and I get it. We can't retain people if we don't have them, but we really need to be bringing retention into focus. I think now, especially given the current context within the global pandemic, many trials have had to halt or pause recruitment, but we're all still trying to follow up participants. We're adapting to changing circumstances, using modes and methods of delivery and data capture that we haven't used before, for which there is little to no evidence. And we really need to be thinking critically about what might work best. So whilst this research agenda had identified retention as one of the top priorities, what it didn't do was it didn't identify what the research questions were that needed answered for retention. So off the coattails of priority 1, which was for prioritizing recruitment in randomized trials, we ran priority 2, which looked at identifying the top priorities for retention in randomized trials. And this was a James Lind Alliance prioritization setting partnership. I'm not going to go into the details of the project, but what I will tell you, if you haven't seen already, is that we identified this top 10. So I identified 10 core questions. And again, I would encourage you to go to the website to have a look at these in detail, that were supported by the trials community. So this wasn't the steering group's top 10. This was the top 10 generated by the UK and Ireland's trials community. And generally, I'm not going to read them out individually, but generally these broad questions are around barriers and enablers, informed consent, patient public involvement, technology, trial burden, but also the impact of recruitment on retention. And this is something that I want us to think about now, but also as we go throughout the talk. So what was really interesting to me was that 5 of the questions in both top 10s, sorry, 5 of the questions featured in both of the top 10s. And really, I don't think we should ever be thinking about one of them without the other. So what are we doing during recruitment, for example, that can impact on retention, and how should we be assessing and evaluating that? So these were all the unanswered questions. What do we know about how to improve retention in clinical trials? So the answer is not a lot. So right now, the Cochrane Review on strategies to improve retention in randomized trials has identified one thing. So there's one thing to improve retention, and it's only to improve response of postal questionnaires, and that is monetary incentives. So we know money, financial incentives work to improve postal questionnaire responses. I should say at this point that we're in the midst of updating this Cochrane Review, and that we hope that results will be out later in the year, early next year. And if you stick with me, I'm going to give you a bit of a spoiler and reveal some of the results as well that we know will be in this updated version. So this is all great. In this Cochrane Review, as it stands, there are 34 trials evaluating a whole range of different interventions. But do we know if these interventions are valued, are appropriate, are even set in the accounts of participants who find it difficult to stay engaged in clinical trials? So to address this question, we wanted to know, what do participants say? So we conducted, myself and colleagues in Aberdeen, Zoe Ski and Rumana Newlands, conducted a qualitative evidence synthesis that looked at any participant reported reason for not completing some or all of the processes involved after the point of consent in a trial. And this piece of work taps into 2 of these priority areas I highlighted before. So I'm not going to go into the methods, I'm just going to give you the highlight of what this study showed. But before I get to it, again, thinking about how much research is done on recruitment and how much is done on retention. We predicted that a similar study on retention based on one conducted earlier would have yielded around 50 results, if not more, for inclusion. We identified 11 studies, and there are a couple of reasons for that, which I'm happy to talk about in questions later. But what did we find? So essentially, we found that personal compatibility matters. Okay, and we believe that all of these different impacts from the trial are set against this context of the broader life events and challenges, and there's this complex interrelationship between the individual and the trial processes and procedures. But one of the big things that came out was that it appears that there is this suboptimal informed consent process. And it raises important issues around the extent to which initial decisions to participate in a trial are actually fully informed. And it illustrates the importance for trial recruiters of ensuring that prospective participants are made aware of the expectations on them as participants, but also what they can expect of the trial in terms of full participation. So let's think about this idea of informed consent, okay? What do we know about how retention is discussed? So if we look at the information, so informed consent has really 2 components to it. For most trials, there will be some written information and some verbal information. So in terms of the written information, there's a nice piece of work, again, Anna Kearney, Carol Gamble and colleagues in Liverpool, that analysed patient information leaflets for UK trials. And what they found was that 98% frequently reiterated the right to withdraw, and 90% of those without having to give a reason and without penalty. And only 16% contained a statement about the value of retention. Now, this goes against principles of informed decision-making, where you would provide participants with the consequential information about what doing one thing means. So what, if you withdraw, what does that mean for your involvement in the trial, for other people, things like that. Karen Innes, one of our trial managers in Aberdeen, conducted some work to look at what information items people believe are important when making a decision about taking part. And again, at number 3, one of the items, what will I have to do? So the expectations on them as a participant. Now, this might not be surprising, because actually when we look at regulatory guidance, such as the Declaration of Helsinki and the ICH GCP guidance on what information needs to be provided, they don't really go beyond stating that the participant must be informed of the right to refuse to participate or to withdraw consent at any time without reprisal. or extended into the expected duration of their participation. But as I said, informed consent contains both written and verbal information. So we decided in Aberdeen that we would run this study to look at what is said about retention during informed consent. So we, in a couple of our trials, routinely audio record the recruitment consultation to explore how recruitment is discussed. Pamela Tunji-Ajayi and Ailey Duncan and I decided then, well, what about if we use those audio consultations and ask the question of how do people talk about retention? So was retention discussed in these consultations? This was in one trial, and again, at the end, I'm happy to answer questions to give you more detail. But around 79% of consultations had no discussion of retention, okay? Of those that did discuss retention, the maximum proportion of time spent discussing it was 3%. So that's 1.5 minutes of the consultations we analysed spent discussing retention. And again, in those that that discussed retention, 25%, so a quarter of them, the patient prompted that discussion. So the patient initiated asking questions about retention. And what types of things did people say? So I'm going to give you a couple of examples just because I think this really helps bring this issue alive. So this is a researcher talking to a patient, okay, about taking part in this trial. And they say, so there's a consent process that I'd go through, a consent form that you fill in. You can withdraw your consent at any time. So if you fill it in, your consent form today, decided you didn't want to do it, and then you went home, thought about it and thought, actually, no, this isn't right for me, you can withdraw at any time. Again, with the follow-ups. So the follow-up questionnaires, you can always decide when life gets busy and gets in the way, if you decide, oh, I've not got time to do these questionnaires or too much other things going on, again, you can choose to withdraw from the follow-up as well. So if you decide to go into this study, it's not set in stone. You can withdraw at any time, all right? So hopefully that pushes home the point that it's really being reinforced that you have the right to withdraw at any time, but none of the consequential impacts of that are also being explored. But there were some examples of good practice. So people talked about, saying, I'll show you a copy so you know what's expected of you, and then ran through the questionnaire with people. And also talking about completion of the questionnaire is also a way of confirming your ongoing consent. So there were examples of good practice. But to me, one of the most surprising findings in this piece of work, that was when we fed this information back to site staff at an investigators meeting, was they said, well, it's not our problem. And again, I can talk about why we think that that was the case later on, but anybody who is in the business of trials, retention is their problem. We all need to worry about retention. We're all in this same boat. And if that boat springs a leak and we start losing participants, we should all worry about it because it means we're going to have to recruit more of them. So if you see your job as a trial recruiter, retention should still worry you. It should worry all of us. So as an extension of part of this work, we have a PhD student, Taylor Kofi, and he is going to be looking at this problem in more detail and using a behavioural approach to try and unpack some of this. And I'll tell you a bit more about this behavioural approach in a second. And also to say that other researchers, so Anne Dakin and colleagues in Bristol and Liverpool have done this nice piece of work, which I think, the title tells you all, recruitment, recruitment, recruitment. And one of the quotes in the study talks about nobody's interested in retention. And what it starts to also highlight, and I can only talk from a UK context, is that we have these perverse incentives within our infrastructure that really put recruitment over and above any other aspect of the trial, whereas really the trial will only be complete if we collect the data on those people that we recruit. So there is some infrastructure changes that may also need to happen to help support retention going forward. So I mentioned on that last slide that we're starting to think about retention as a behaviour, and that might sound a bit odd. So what do I mean by that? So if we think that many of the causes of poor follow-up in a trial are to do with people performing or not a behaviour. So that might be returning a questionnaire, it might be attending a follow-up clinic. Okay, and all of those, when we invite people to take part in our trials, we are asking them to do something different. We are asking them to change their behaviour. So if we start to think about problems of recruitment and retention through a behavioural lens, it might mean that we can lean on some of those theoretical frameworks to help develop interventions that are maybe potentially more replicable and more effective in different contexts. So a team in Aberdeen a couple of years ago developed a theory-based cover letter. So this is the cover letter that goes with the standard questionnaire for your trial follow-up. They tested a standard letter versus a behavioural theory-informed cover letter, okay? And they've tested that intervention and replicated that in a couple of trials, and this is the spoiler that I mentioned before. So when we look at that meta-analysis of that intervention, you can immediately see that there is an improvement in the response rates. In fact, there's, for retention terms, a pretty decent sized improvement. So 4.4% absolute increase in the number of questionnaires returned. So this is going to be one of the new findings in our updated Cochrane review. This data will be there. And I'm going to tell you in a little while as well about how you can implement some of the findings from these new interventions. But if we come back to a minute, I mentioned earlier, you know, how embedded are these interventions for retention and indeed recruitment, embedded in accounts of participants and identify things that participants say matter to them in developing interventions. So we have a project called Steer, which has done exactly that. It's spoken to people who've dropped out of trials and asked them what would have helped. And then using a behavioural theory, behavioural framework, we have developed behaviour change interventions to be tested in randomised evaluations. And we're also starting to use this behavioural approach to think about retention and start to try to identify the active ingredients within existing retention interventions to think about mechanism of action. Okay. So coming back to solutions. So I told you at the beginning that I'm not going to give you a magic solution. I'm not giving you a silver bullet of this is how you fix everything. But we can start to look at some of the evidence and think about how it maps onto some of those priorities we talked about early on. So if we think about the Cochrane review of randomised evaluations to improve retention to trial, in the update, I can tell you that there is going to be evidence that hits many of these priorities from the previous prioritisation exercise. It won't answer the questions fully, but it will certainly give us a lot more than we have already. Adel El-Feki, who was a PhD student with us, who successfully defended his thesis earlier this year, one of the parts of his PhD work was a systematic review of non-randomized evaluations of retention interventions. And essentially, so it has this question mark of what the evidence tells us, but essentially, because of the poor design of many of these studies, it tells us nothing in terms of what works. What it does suggest is that there may be interventions within those evaluations that could do with being evaluated in a randomized comparison. So has promise, but nothing we can say definitively right now. I told you very briefly about the meta-ethnography that we had conducted, so this qualitative evidence synthesis. And really this starts to tap into some of the questions around motivations and experience. But again, there's not enough. So what I didn't say was if we consider the context of many of those studies, there are still many gaps. So we don't really know a lot about how to engage children in trial retention or adults who lack capacity, so proxies for these people. So there's still a lot of work to be done. And much of the reason that this is challenging, along with other aspects of trial retention research, is that people who disengage with trials are hard to re-engage in other research. And so it would be great to hear from other people who are exploring ways in which we can do that effectively. Other research that I haven't really spent time talking about today, but you may be aware of, is there was a systematic review on the impact of patient-public involvement on recruitment and retention in the BMJ at the end of 2018. This was led by Joe Crocker from Oxford. Whilst it looks like there may be an impact on recruitment, nothing can be said about retention, largely because there weren't many studies, and in fact, of the 6 that there were, only 1 of them had retention as a primary outcome. And then also this systematic mapping review from Jeff Frampton that was published earlier this year in Trials. And again, it shows potential promise in some of the interventions, but none of them were evaluated in a robust way to be able to definitively say whether one is better than the other. So really we need to continue to add to the evidence base, and how do we do that in a meaningful way? Well, this isn't just going to be, you know, a couple of research groups doing this. This needs to be a concerted, collaborative effort, and there are certainly steps underway to enable that to happen. So I'm sure many of you will have heard Sean Treweek talking about SWOTs, so these are studies within a trial. And these don't have to just be randomized evaluations, they can be non-randomized evaluations, including qualitative explorations of the reasons why people do and don't drop out, or what their experience of a trial has been, why they stay committed till the end. So more of this type of evidence needs to be generated. And in fact, thinking about SWOTs, you know, we really as a research community don't have an excuse for not doing this anymore. So funders are behind this. So here in Ireland, here in the UK and over with you in Ireland, the HRB-TMRN and NIHR both now provide dedicated pots of money to support the introduction of SWOTs within existing trials. And there's also Prometheus, which is a program of work led by David Torgerson from York, looking at promoting the use of SWOTs, so a systematic approach to identifying and rolling out these strategies in trials. And if you're interested and want to find out more about SWOTs that are ongoing at the moment, if you head to the SWOT repository, which is hosted by Queen's University Belfast and the Northern Ireland Hub for Trials Methodology Research. And we're doing some work at the moment to map the existing SWOTs against the evidence to come up with a prioritised framework of where we should be focusing efforts. And that's being done in association with the Trials Methodology Research Partnership in the UK. So that's what you can do now in terms of trials method research, but what about for your trial? What could you do right now when you go back? Okay, so I said at the beginning, if this was about, you know, fixing the leaks, and I'm not going to teach you to be a plumber, but hopefully I'm going to give you some tools that might help you to address some of those problems. So the first thing is keep an eye out for the Cochrane update. It will be coming out, as I said, hopefully end of this year, probably early next year. And the thing right now that you can do is you can use money to influence the postal response rates. That is going to make it, that's likely to make a difference. There are also those theory-informed cover letters I mentioned to you. And the theory-informed cover letters, you know, you may be thinking, well, I have no idea what that's going to look like. So through TrialForge, there's the development of implementation packs, which contain templates of these letters that you can pick up, add information about your trial, and then run it in your trial. There's text for what to use in the ethics application, of how to get through the regulatory approvals of these types of interventions. So have a look there. I can't encourage enough the importance of engaging early and meaningfully with patient partners for retention. So I think really thinking critically about how each step of your trial does or doesn't impact on retention, it is really important to think about mitigating against these leaks springing up. And importantly, this idea of what happens in the recruitment consultation. So go and have a look at your patient information leaflet. What does it say right now about the expectations? What is it asking people to do? And also, what do your recruiters or research staff say to people when they're telling them about your study? Ask them, see if they mention retention. Then other initiatives to look out for are Will Cragg, and you may have heard his webinar last week on Persevere. So he's developing some principles on thinking about what to do when people want to stop early. And that again will be coming out probably later this year, early next year. And I'd also encourage you to get involved with the Trials Methodology Research Partnership. Again, we have a program of work on retention. And then priority 2. So I showed you that this project had generated a research agenda, but it was one of our patient partners, Andrew Worrell, who made me think slightly differently about this as well. You can use the priority research questions as a way at the beginning with your patient partners to think about, have you addressed some of the key concerns that might come up for your trial about retention? I think that's a really neat way to think about using that research agenda in a slightly different way. And so to finish, I'd like to bring us back to thinking about the overall theme of the symposium and how this relates to retention. So if we think about improved trials for better health decisions for an informed public, so there's an obvious link there, right? With retention, it's what I spoke about right at the beginning, that if poor retention leads to concerns over the accuracy and the validity of the trial's results, it then has no ability to influence clinical practice. And so patients and the public can't make better health decisions based on that evidence. But there's also a less obvious implication as well, which is participants, when making decisions about their healthcare, of which taking part in a trial is one, if they don't have the right information about the expectations on them as participants, both at the beginning of the trial and for its duration, so what's expected of them, or when incentives or when theory-based cover letters are sent to them, that they're not aware of the importance of completing the trial until the end, then really this also has an impact on them being able to make informed choices and ultimately make better decisions about their own continued care within a clinical trial. And so that really leaves me to end on the old saying that by failing to plan for retention, we are essentially planning to fail. And last of all, then, I'd like to thank all of you for hopefully being retained through this talk and staying with me until the end. All of these people in this slide for their contributions to both existing and ongoing projects, and also to all of the funders. Thank you very much.